All right. Hello, everyone, and welcome back to our next lecture. This is going to be a topic of endocrinology. So if you haven't watched the tutorial video on endocrinology and the hypothalamic pituitary portal system, go ahead and watch that tutorial. This is going to be the full lecture of that. So this is the full endocrine system. So with endocrinology, we're dealing with hormones. We're dealing with the concept of hormonal regulation. Hormones are going to be classified because of the target that they go to. So we have things such as autocrine hormones. Those are going to be ones that are secreted and exert their effects directly on the same cells or on the identical cells that are close by. We have a paracrine secretion, which is going to exert its effects on the surrounding tissue, right? Doesn't enter the bloodstream, it just stays in the surrounding interstitial fluid in the same cells. Neurocrine hormones, those are neurohormones. These are going to be secreted through neuron tracts. So our examples are ADH and oxytocin, when we had the posterior pituitary insertion of those hormones that were made by the hypothalamus and sent down via the neurohypophysis to posterior pituitary in order to be stored. So back when we originally defined this as a hormone, this is originally going to be because we thought it was going to be secreted into the bloodstream. Okay. So a standard hormone that we know of, classical hormone, is going to be one produced by an endocrine gland. It's going to be sent into the bloodstream and it's going to reach a target or a distant tissue. So it's going to circulate around the body and find wherever it's going. This is known as a classical telecrine secretion. Okay. So telecrine secretion was originally thought to be the only type of hormone that existed because we could only register it in the bloodstream. Now, however, we have these additional hormones that we see are different in classification. So the traditional bloodstream-bound hormone or endocrine hormone that goes through the blood is known as a telecrine secretion. There are the other kinds here represented that are also hormonal, but they do not enter the bloodstream. So we have three types of hormones that we talk about. Hormones are almost always going to come from some sort of protein backbone. So we have types of hormones that are going to be protein or peptides. We have amino acid derivatives. These are also known as amines. And then we have the subgroup of steroid hormones. All steroid hormones are derived from cholesterol molecules. So if we see down here, this is a standard ring base structure of cholesterol. So this cholesterol ring structure is going to be the base for all steroid hormones. It's going to contain 17 carbons in this linkage. And we have our 4 cyclical structures. We have 3 hexose rings, hexose meaning 6, and we have 1 pentose ring, pentose meaning 5. 6 sides for these 3, 5 sides for this 4th one, right? The protein or peptide hormones are going to be either classified as polypeptides or glycoproteins, and they can range from 3 to even thousands of amino acids in length. Ones that are derived from amino acids are not technically protein or peptide hormones because they're not the proper amino acid structure anymore. So they've been broken down from their traditional amino acid parental molecule. Amino acid derivatives that we see coming from tyrosine are things like thyroid hormones, T4 and T3, thyroxine and triiodothyronine, respectively. We also see the catecholamines, which are secreted from the adrenal medulla. This is epinephrine and norepinephrine. So classifying hormones based on their structure. Most hormones are going to have receptors that are going to be on the surface of the cell or on the cell membrane. Extracellular receptors are going to exist for our glycoproteins, polypeptides, and amine hormones of norepinephrine and epinephrine. Steroid hormones are going to be special in that they are able to easily diffuse across the cell membrane. They are based on the cholesterol structure, which is a lipid, so they can easily diffuse through the hydrophobic section of the cell membrane. That means that they have cell receptors on the intracellular space. They are either in the cytosol of the cell or on the nucleus of the cell. So the intracellular receptors exist for our steroid hormones and also for the amine hormones of the thyroid, T3 and T4. Another way we can look at this is water solubility, right? So if it is water soluble, it's going to be a glycoprotein, polypeptide, or epinephrine and norepinephrine. Lipid soluble are going to be these steroid hormones, right? So if we have a lipid soluble hormone, it's going to have an intracellular receptor. Our classifications of glycoproteins are going to be things such as follicle stimulating hormone, thyroid stimulating hormone, luteinizing hormone, and human chorionic gonadotropin, which exists only in fetal growth or in a pregnancy situation. Polypeptides, right? These are going to be large protein chains. Examples are going to be things like ADH or antidiuretic hormone, oxytocin, growth hormone, cholecystokinin, which is CCK, calcitonin, etc. Our steroid hormones based off of cholesterol. These are your traditional steroid hormones, sex hormones, things like estrogen, estradiol, progesterone, dihydroxytestosterone, testosterone, vitamin D. Our amine hormones, again, we have derivatives of tyrosine here, norepinephrine, epinephrine, and the thyroid hormones. Our first classification is going to be the amine hormones. The amine hormones derived from the amino acid tyrosine. Number one, we have the thyroid hormones. Our two classifications, T4, which is thyroxine, T3, which is triiodothyronine. Both of those are derived from the thyroid gland. Right? So they can easily cross cell membranes. So they do have intracellular receptors. They're transported in the blood bound to large plasma proteins. Our other two are going to be the catecholamines. The catecholamines are not able to cross the cell membrane readily, so they are going to have extracellular receptors or cell membrane receptors. They're going to be a little bit smaller than the thyroid hormones, so they don't need as much transport help within the blood, so they can be transported in the blood as free molecules, not bound to anything, or they can become loosely associated with cellular proteins. All right, our steroid hormones, all of which derive from cholesterol. They have an intracellular receptor, and this is because they are lipid soluble, so they are nonpolar in nature. They're going to be somewhat large, so they're usually going to be circulating bound to a protein. They need some sort of a transporter. They are secreted as they are needed. They have no storage ability, so that means that they are going to sit and circulate until they are used. And they are produced based off of a need. So they have a cyclical, undulating secretion pattern. Third classification, the peptide. Okay. Peptide hormones are going to be a classification of a short chain of amino acids, so anywhere from 3 to 20 or so. And the protein hormones are going to be the longer chains of amino acids. So we're going to synthesize these from what are called prehormones. Proteins and peptides are relatively polar because derived from amino acids which have polar ends. So they often are going to be circulating in the blood unbound. Their cell membrane receptors are going to be on the outside of the cell. We're not going to have transport across the cell membrane. They are not soluble through lipid. Most of these protein hormones are going to be where we get the second messenger hypothesis from. What this means is that the hormone that binds to the cell surface or the receptor on the cell membrane is going to initiate a first messenger signal. That means that our hormone itself is going to be the initiator of the sequence. Secondly, there's going to be a hormone binding intracellular release that happens after we have the receptor stimulation. And this is known as the second messenger. So we have binding of molecule, binding of hormone by the cell membrane receptor. Then we have signal transduction to the intracellular space where we stimulate the activity of a second messenger. Some examples of second messengers are things like cyclic AMP, cyclic GMP, calcium and phosphatidylinositol. Right, those are going to be common second messengers that we see that are going to transduce down inside of the cell to take a signal from an extracellular receptor for a protein or a peptide hormone. All right, so hormone action. Hormone action is going to be a large feedback loop, pretty much. So they're going to initiate by attaching to receptors either on the cell surface or inside of the cell. We know that receptors are going to be proteins in nature. So receptors are going to be proteins, whether they be on the cell surface or inside of the cell. On the cell surface, we have things like amine and protein hormones that are going to be targeted and attached here. In the cytoplasm, we're going to have things like steroid hormones that are going to be targeted. And on the cell nucleus, we have thyroid hormone that can be targeted by the receptor here. A lot of our hormones are able to regulate their own receptor concentration. And what that means is that the more hormone that is present circulating around, the less amount of receptor density that we'll have. If there's less hormone circulating, the more amount of receptor density we'll have. And these are known as down and up regulation, respectively. Upregulation is the concept that we have an increase in receptor number and sensitivity if we need more activity from the hormone. Downregulation is the opposite. We have decreased receptor number and activity or sensitivity when we have an increase of hormone or a excess of circulating hormone. So regulating hormone secretion comes through 3 loops. Hormone secretion is controlled by feedback loops. 90% of these are going to be negative feedback. About 10% is going to be the positive feedback loop. So what we see from negative feedback loops is that we have functional feedback from 3 different sections. Number 1 is going to be the long loop feedback. This is where we have the target organ or target tissue feedback all the way to the stimulating hormones in the neural hypophysis. So for example, the target organ is going to feedback negatively onto the hypothalamus or the pituitary gland, and that is going to either up or down regulate the amount of hormone being released. We see this with negative feedback pretty much all over the place. Our example of positive feedback that happens in this mechanism is going to be a luteinizing hormone surge, which is going to happen at the time of ovulation. Luteinizing hormone will continually be secreted in a large amount as we get ovulation of the oocyte inside of the female reproductive tract. Short loop feedback is going to evolve from the hypothalamus to the anterior pituitary. This is going to be the releasing hormone and stimulating hormone, respectively. If there's a lot of stimulating hormone being released from the pituitary gland, it's going to feed back onto the hypothalamus and slow down the releasing hormone secretion so that we have less stimulation. The opposite of that would be if we have less stimulation of the actual anterior pituitary, and therefore will feed back onto the hypothalamus to start secreting more releasing hormone to upregulate the amount of hormone being released. Finally, ultra short feedback is going to be where we have the releasing hormone secreted feeding back on itself. So ultra short loop feedback, for example, is going to be a hypothalamic releasing hormone being secreted, and then either large amounts or small amounts of that is going to be sensed by the hypothalamus itself. And if we have a large amount of releasing hormone being released, then we're going to slow that down over time because we have a short loop, extra short loop feedback here. So here's some examples of that feedback loop, all right? Our long feedback loop is going to go from target organ all the way back up to the hypothalamus. Our short feedback is going to go from anterior pituitary to the hypothalamus, or from the hypothalamus to the pituitary. And the ultra short feedback is going to go from hypothalamus back to hypothalamus. So just right in here. Now, types of endocrine pathologies. Endocrine pathologies are relatively common. We hear of hypo or hyperthyroidism all the time. So in the example of thyroidism, here we can see our types. This is either first, second, or third degree hypo or hyperthyroidism. Hyper means oversecretion. Hypo means undersecretion. So in the case of first degree hyposecretion, this is where we have thyroid hormone that is not being made in the case of the thyroid gland to an adequate degree. In second degree, this is where we have thyroid stimulating hormone that is not being made to an adequate degree in the anterior pituitary. If it's third degree, that means it's all 3 systems. That means that the hypothalamus is not making enough releasing hormone, so therefore we don't have enough stimulating hormone and don't have enough thyroid hormone. Similar here for hypersecretion, just the opposite. First degree hypersecretion is going to be overstimulation of the thyroid gland producing thyroid hormone. We see this in tumor circumstances where we might have thyroid cancer, right? This tumor is going to cause oversecretion of thyroid hormone because we have an excess of production due to proliferating cancerous tumor tissue. Second degree is going to be overstimulation by the thyroid stimulating hormone. And then third degree is going to be overstimulation by the releasing hormone from the hypothalamus. An ectopic is going to be something outside of the initial tract. So something outside of the hypothalamus, pituitary, and thyroid axis that is causing secretion of thyroid hormone to a larger degree. So this could be something like medical treatment, like radiation or thyroid therapy, or if we give exogenous stimulating hormone, like if we have a patient who needs to increase their metabolic rate for some reason, and we administer thyroid stimulating hormone that doesn't come from the pituitary, it's given from outside of the body, then we can have an upregulation in thyroid hormone secretion that's from a third-party source or an ectopic source. So our first hormone of note that we're going to go through is vasopressin, or ADH. So ADH is antidiuretic hormone, antidiuresis. Main effect is to conserve water. So it's going to have a couple of different actions. Number one, contracts the vascular smooth muscle. That is going to slow down the flow of blood to the periphery. It's going to increase blood pressure and cause the heart to be able to pump more. It's going to utilize PIP2, which is phosphatidylinositol biphosphate, and that is going to be a second messenger for this. So this is going to have an extracellular receptor known as the V1. The antidiuretic effect is going to go directly onto the kidneys. This is via the V2 receptor. This is utilizing cyclic AMP as a second messenger, and we're going to increase the permeability of the distal tubules and collecting duct of the kidney nephrons by inserting what are called aquaporin channels and allow for increased water reabsorption in these places that are typically not that permeable to water. We also have the case of diabetes insipidus here. Diabetes insipidus occurs when there's a lack of ADH or ADH-V2 receptor. That means that we're going to have excessive dispersion of water out into the urine. So we can have polyuria or excessive urination. For the regulation of ADH secretion, two mechanisms. One is osmotic regulation. Usually we keep the osmotic pressure of the plasma around 290 milliosmoles per kilogram. So a decrease in that osmotic pressure is going to result in the inhibition of osmoreceptors. And that is going to be from no release of ADH, right? So the osmoreceptors in the anterior hypothalamus are going to increase the neuronal firing rate to stimulate the release of ADH. Blood volume regulation comes from low pressure. So if we have a decrease in plasma volume, a decrease in blood pressure, it's going to result in the removal of the inhibition of ADH secretion. So we'll have stimulation of ADH by low blood pressure. The baroreceptors are going to exist in the aorta and the carotid arteries, and they're going to sense pressure. They are high pressure receptors. A perceived drop in blood pressure from these baroreceptors is going to remove the inhibitory afferent activity and is going to increase the activity of the vasopressin secreting neurons. Other factors that we have here, pain, surgical stress, both of which increase ADH, so that causes you to hold on to water. Alcohol is a diuretic agent, so this is going to cause decreased ADH, causes net loss of water. Next hormone up is oxytocin. Oxytocin is a peptide hormone. It's going to be released from the hypothalamus, stored in the posterior pituitary gland. All right. Actions of oxytocin. Number one, increasing uterine contraction during childbirth. So in this contraction, and this is the traditional labor contractions that we have. Number two is inducing the contraction of the myoepithelial cells. That has to allow for the milk in the mammary gland to be let down into the areolar region. And number three is going to sense a response to the neuroendocrine reflex, which is going to be the reflex for the suckling of the child. All right. So it's going to respond to that neuroendocrine reflex, which is going to stimulate the milk to be let down, which is going to allow for breastfeeding. Our hypothalamic hormones, again, we went over this in the tutorial a little bit, but I will revisit it here. Number one, we go by our abbreviations here. So luckily, the abbreviations are going to mimic the name exactly, and the names are going to indicate what the hormone does or where it goes to act. So first, thyrotropin releasing hormone. This is going to go and stimulate the pituitary gland to secrete TSH, or thyroid stimulating hormone. Gonadotropin releasing hormone. This is known as GnRH. This is going to stimulate LH and FSH release from the pituitary. GAH, which is somatostatin, growth hormone inhibiting hormone, right? This is going to be secreted, and it's going to stop the release of GH from the pituitary. Growth hormone releasing hormone, the opposite of somatostatin. Here we have GRH, which is going to stimulate GH release from the anterior pituitary. We have CRH, which is corticotropin releasing hormone. This is going to work on the fasciculata cells in the adrenal cortex, secreting cortisol during the stress response. Prolactin releasing factor, which is PRF. This is going to stimulate prolactin release from the pituitary gland. And then we have PIH, which is prolactin inhibiting hormone, which is otherwise known as dopamine, and that's going to inhibit prolactin secretion. Our anterior pituitary hormones, we're going to have the ones stimulated by the gonadotropin releasing hormone, which are FSH and LH, follicle stimulating hormone and luteinizing hormone, respectively. We have TSH stimulated by TRH. This is going to be a thyroid stimulating hormone, also known as thyrotropin. Then we have GH, or growth hormone. We have prolactin, and we have adrenocorticotropin, which is going to go onto the adrenal cortex. All right, first hormone of note here is prolactin. The action of prolactin is to initiate and maintain lactation, which is milk production. We have mammogenesis, which is a prolactin action. This is causing growth and development of the mammary glands. We have lactogenesis, which is the initiation of lactation. And we have galactogenesis, which is the maintenance of milk production. It's under the control of dopamine, right? So prolactin inhibiting hormone is going to be the predominant regulator here. The release is going to be stimulated only by a few things, and those are usually going to be during childbirth and after the short period of infancy. It's going to be nursing, all right? So when you have the suckling response, you have a baby that is constantly being breastfed, the nursing response is going to stimulate prolactin release. Sleep, you have increased prolactin secretion during sleep time. Estrogen, okay? Increase in estrogen is going to cause stimulation of prolactin release, and also dopamine inhibitors. So if you take a dopamine inhibitor, or if you have a pharmaceutical that inhibits dopamine, it's going to also upregulate prolactin activity. All right, so next is going to be energy metabolism. When we talk about energy metabolism, a lot of what we talk about hormonally is going to be thyroid hormone, right? A lot of what we talk about as far as regulation is going to be from different areas. Main regulators are going to be the liver, adipose tissue, and skeletal muscle. Normally, our energy reserves are going to be in the form of glycogen, which is glucose. So glucose is our preferred cellular energy for pretty much all cell types. Blood glucose is going to range between 90 and 120 milligrams per deciliter, and that is going to be a resting value. So normally the resting value of blood glucose is going to be under 100 milligrams per deciliter. In the case of diabetes, it's usually going to be above that, right? So 140, 150 milligrams per deciliter at rest can indicate case of diabetes. Blood glucose is the most important when it comes to neural tissue. So the brain, neurons, glial cells, and red blood cells. These are all going to be very contingent upon glucose for their energy substrate. Our metabolic processes that exist when we go with metabolism are going to be in the form of carbohydrate. We have glycogenesis, creation of glycogen, glycogenolysis, the lysis or cleavage of glycogen, and gluconeogenesis, which is the creation of new glucose that can happen in the liver and the muscle. And we have lipogenesis, which is the creation of adipose tissue or stored fat. We have lipolysis, which is the breakdown of that stored fat. And we have protein synthesis, which is the creation of proteins. And we have proteolysis, which is the breaking of those peptide bonds to indicate individual amino acids being made. We have two metabolic states. We have the fed state, which is going to be around the time of dietary intake. This is going to increase glycogenesis, which is going to be increasing storage of glucose. It's going to decrease gluconeogenesis, so we don't produce as much glucose from the liver because we don't need to. It increases lipogenesis, the storage of fat, decreases lipolysis, decreasing the amount of fat that we are constantly using, and increases protein synthesis in the case of musculature. After we have feeding, insulin goes up, glucagon goes down. Insulin goes up so we can transport that glucose and other nutrients into the tissues. Then we have the post-absorptive state, which is known as the fasting state. So this is going to come in the intermediate times between meals, usually 3 to 4 hours after intake of a meal as we start to enter the fasting state. This is where we have a decrease in blood glucose and we have an increase in glucose production. So during the fasting state, insulin is low, glucagon is high. Glucagon is going to be stimulating hepatic processes of glycogenolysis and gluconeogenesis. Muscle glycogenolysis is also going to be taking place. Blood glucose, again, is maintained by the liver. We have insulin and glucagon being secreted from the pancreas, and then we have blood glucose maintenance by the liver. We have some release of free fatty acids during this time. It's going to be contingent on carbohydrate availability. So if we have little or no carbohydrate storage, and all of it is coming from gluconeogenesis processes in the liver and the muscle, then we're going to start cleaving off fatty acids from the adipose tissue so we can aid in the metabolic processes that don't have enough energy. All right, major hormones of energy metabolism. Here we get back into the endocrine nature of things. We have the pancreas ones, insulin and glucagon, right? Insulin is going to be secreted at times of fed state, glucagon during times of fasting. We have catecholamines. Basically, epinephrine is the important one here when we talk about energy metabolism. This is going to come from the adrenal medulla. We have cortisol, which is coming from the fasciculata cells of the adrenal cortex, and we have growth hormone from the anterior pituitary. So here we have the regulation of growth hormone. Growth hormone is going to be secreted by the anterior pituitary. It's going to be stimulated by a growth hormone releasing hormone, or GRH. It's going to be inhibited by somatostatin. And we can see the feedback loops that are going to be registering what we have here. So we have secretion by the anterior pituitary. That secretion is going to be short loop feedback onto the hypothalamus, down-regulating or inhibiting GRH release. We have the long loop, which is going to go from the distant tissue cells in the liver that is going to work back onto the anterior pituitary and the hypothalamus if there is enough circulating GH already. IGF-1 is going to be what is stimulated by GH. IGF-1 is going to be stimulated. It's known as insulin-like growth factor 1. And this is going to mimic the actions of insulin, and it's going to stimulate the processes of glycogenolysis, gluconeogenesis, and putting more glucose into the bloodstream. All right, growth hormone secretion, regulation. Stimuli are going to be as follows: exercise and fasting, all right? If there's low blood glucose levels, which is known as hypoglycemia, then it's going to stimulate growth hormone release. Also, stress, right? Any sort of stressful thing that happens to the body stimulates growth hormone. If we increase our plasma amino acids, such as arginine, This will also increase GH secretion. And mostly our natural cycle of GH release comes from sleep onset. So in a normal given person, you will have GH secretion be the greatest at the time of nocturnal onset, so the onset of sleep. And this is within 1 to 2 hours after going to sleep. Inhibiting GH secretion, if we're in the fed state, so we have increase in glucose and free fatty acids in the plasma, this will inhibit growth hormone secretion. And other hormones, especially steroid hormones and stress hormones like cortisol, this is going to be another factor that's going to inhibit GH. Growth hormone effects, we have a direct effect on metabolism, going to increase the metabolism of cells and tissues. We have an indirect effect, which is going to be caused by that insulin-like growth factor. Insulin-like growth factor, also known as a somatometin. So somatotropin is growth hormone. Somatostatin is the inhibition hormone for growth hormone. Somatometins are known as insulin-like growth factors. Insulin-like growth factor 1 is what we will see in normal adulthood. Insulin-like growth factor 2 is going to be another growth factor that's going to be released during puberty or adolescence. Insulin-like growth factor is going to come from the liver, right? As we saw in our previous graphic, we have growth hormone stimulation of the liver production of IGF-1. It's going to circulate bound to our plasma proteins. The direct effects, right? We have metabolic effects that are the direct effect of growth hormone. It's going to increase plasma glucose, increase mobilization of fat, increase protein storage, promote lipolysis, increase glycogenolysis, inhibit glucose uptake in the muscle and adipose tissue. The effects of the IGFs, right, or the insulin-like growth factors, those are going to act on soft tissues. So we see increase in cell proliferation and protein synthesis, as well as an increase in bone growth or osseous formation of the skeleton. Pathologies that we see here, growth hormone deficiency is going to be differential based on childhood or adulthood. In childhood, if we have growth hormone deficiency, this can severely hamper our ability to grow to a normal skeletal size. So in childhood, if we have GH deficiency, this is going to be basically how we get dwarfism. A Larin dwarf is going to have no circulating somatometins. So growth hormone is still there. Growth hormone just has no effect on the growth of tissue through IGF. A pituitary dwarf is going to be a growth hormone specific deficiency. This is going to be where the pituitary gland itself is not able to secrete growth hormone as it should. Finally, genetic IGF deficiency is also known as a pygmy. This is where we have no circulating IGFs. In adulthood, growth hormone deficiency can cause mild hypoglycemia. Right? So we see that during childhood, growth hormone deficiency has a lot of things that can complicate growth. During adulthood, growth hormone deficiency is not quite as severe, but we can see cases of mild hypoglycemia. Growth hormone excess, this is going to be the other way around, right? Increased plasma glucose. In childhood, this is going to cause gigantism, right? So this is mainly going to affect bone growth. Just as we saw with deficiency, we had bone growth be inhibited, that leading to dwarfism. Here, during childhood, gigantism is going to be the opposite of that. We have excessive bone growth, especially from the epiphyseal plates of long bones. So excessive linear bone growth causing someone who's very tall and lanky. In the adult, this can lead to acromegaly. Since the growth plates on the bones have been shut off, the epiphyseal line is closed. The bones do not grow longer in adulthood. However, they can grow wider, so they can increase in width. And this is known as acromegaly. Right? We can also see increased plasma glucose, which can lead to pancreatic beta cell exhaustion and also insulin insensitivity if we get overstimulation of the receptors there. So this can increase your body organ mass, and the acromegaly is the increase of bone thickening. Right, glucose transport. Glucose transport is modulated by transport proteins known as GLUTs. Right? So glucose transport into the cell is modulated by GLUT 1 through 4. GLUT 1 and 3 is going to be low basal glucose uptake in all cells. GLUT 2 is going to be in the liver and in the kidney. So it's going to be expressed specifically in the hepatic and renal tubular cells. GLUT4 is the most important for skeletal muscle and in the heart. So GLUT4 transporters are expressed exclusively in skeletal muscle, cardiac, and adipose tissue. And this is where we see insulin and sensitivity come into play. These are insulin-dependent transporters, so they do not translocate and open up to the bloodstream if insulin is not present there. So insulin is going to stimulate these transporters to come to the cell surface and to uptake glucose from the blood. Low blood glucose levels in response. All right, so here we have the actions of insulin. Insulin is going to be increasing glucose uptake, especially translocation of GLUT4 transporters. It increases glycogenesis, storage of glycogen, and decreases glycogenolysis. It's also going to increase the amount of fatty acid uptake and amino acid uptake, right? So it's increasing the uptake of all nutrients, increases the free fatty acid uptake, and increases lipogenesis. It is also going to have an indirect effect of stimulating potassium uptake by cells. Insulin secretion is regulated by blood glucose levels. So if we have an increase in blood glucose, it is going to cause an increase in secretion of insulin. This is going to be the main regulator. We also have secondary regulators, the increase in amino acids, especially leucine and arginine, GI hormones, gastrointestinal hormones like gastrin or CCK, nerve stimulation if we have direct stimulation to the pancreatic islets, and if there's an increase in plasma-free fatty acids, we also have insulin increase. Somatostatin is going to decrease the amount of release. So somatostatin is going to be inhibitory when it comes to insulin. We also have a decrease in blood glucose. This is going to lead to a decrease in insulin secretion, as well as decreases in amino acids and free fatty acids. So talking about insulin, we naturally come to diabetes. Diabetes mellitus is known as either type 1 or type 2. So we're defining this by the presence of hyperglycemia. If we have a fasting blood glucose level of greater than 140 milligrams per deciliter, as I mentioned earlier, this is going to be a classic sign of diabetes. If it's sustained above 200 after a glucose tolerance test, you take in a bolus of glucose and then you measure blood glucose levels an hour or 2 hours later, and it's staying above 200. This can be an indicator of diabetes as well. We can have a couple of different reasons for it. We can have a lack of insulin production. Diabetes type 1, we have insulin beta cell destruction, so we don't actually make any insulin. We can have insulin resistance, which is the main method for type 2 diabetes, or we can have counter-regulatory hormones opposing the effects of insulin. So if we distinguish type 1 from type 2, type 1 is where we simply just do not make insulin, right? So we have to take in exogenous insulin from a third-party source. We have to do injectable insulin or get insulin into our body somehow because we just do not make it. Right? It comes because of immune damage, so it's basically an autoimmune disorder that causes destruction of the pancreatic beta cells. Someone with type 1 diabetes is going to be extremely prone to ketosis because we have fat mobilization to an extreme degree. That's going to produce intermediates known as ketone bodies. Ketone bodies can build up and cause toxicity in internal organs very quickly. Usually the onset of this is going to be in children, so it's genetic. The propensity is going to be from ages 10 to 14, 90% of onset is seen here. Most are normal weights, so most are not in the obese category. It's just because of that autoimmune attack of the pancreatic beta cells. And then we do see circulating islet antibodies in the bloodstream, and this is how we can diagnose it. Type 2 diabetes is going to be slightly different from type 1. This is about 80% of the diabetes cases that we see. Usually we're fine with making insulin. Pancreas is able to generate insulin at a normal level. However, it's because we have decreased sensitivity to insulin in the tissue level. So this is a higher genetic basis than type 1 does. Type 1, we usually only see about 5% of heritability there for parents to pass it on. Here for type 2, we see that roughly a third of parents who have type 2 diabetes end up having a child with type 2 diabetes. It's not prone to ketosis because we do have the ability to move glucose around. So insulin is able to be produced, and our body registers that we have insulin in the bloodstream. We just can't get it across the tissues. This is going to occur mostly in adulthood, but we do see onset in adolescents and children as well, based on diet and lifestyle. We don't have any islet antibodies that are circulating because we don't have that autoimmune activity. So the insulin is able to be produced normally. And it's purely due to desensitization of the tissues and the receptors for insulin. The opposite of insulin is glucagon. Glucagon is secreted by the alpha cells in the pancreatic islets. Its major actions are the opposition of insulin. So we have increase in glycogenolysis, an increase in glycogen breakdown, increase in glucose being made by the liver, and we also have increase in breakdown of fatty acids. The regulation of release: if plasma glucose goes up, insulin goes up. If plasma glucose goes down, glucagon goes up. So plasma glucose decrease is going to cause increase in glucagon. It's inhibited by somatostatin, insulin, and an increase in plasma glucose concentrations. Here we have pancreatic somatostatin. All right, so we had somatostatin in the hypothalamic pituitary axis. This was inhibiting growth hormone release. Here for the pancreatic somatostatin, we're going to be inhibiting insulin and glucagon activity. So pancreatic somatostatin is from the delta cells, or the D cells of the pancreas. This is a classified paracrine hormone because it's working on the tissue around it. It's working on the interstitial fluid and the interstitial space around the cells. So the action is to inhibit insulin and glucagon. It is going to be stimulated by increases in plasma glucose so that we don't have too much insulin that's released, and therefore we don't go into hypoglycemia after we have a large bolus of insulin that's made. All right, next is the adrenal gland. Our adrenal gland is where we have the cortex and the medulla. In the cortex, which is going to be 80 to 90% of the adrenal mass, we're going to see the androgens, which are going to be testosterone and things of that nature, secreted from the reticularis. We have cortisol, which is a stress hormone, secreted from the zona fasciculata. And we have mineralocorticoids, such as aldosterone, that are secreted from the zona glomerulosa. The medulla is the inner 10 to 20% of the mass of the adrenal gland. This is where we have the catecholamines produced, norepinephrine and epinephrine, right? In women, we do not have testes, so we do not have large testosterone production in women from a reproductive organ. So that means that 50% of androgens that are made in women are going to come from the reticularis of the adrenal cortex. So here we have to know if the steroids are amine or if the hormones are amine or steroid. Remember that catecholamines are going to be amine hormones, and our steroid hormones are going to be androgens and cortisol and aldosterone. So regulating cortisol secretion. Cortisol is a master stress hormone. It is going to be what causes an uptick in body processes and an increase in activity and alertness pretty much all over the place. So normally it has a diurnal rhythm, meaning that it increases at one point during the day and decreases later on. So the rhythm is going to be an increase in the morning. This makes sense because we want to come towards wakefulness and start the day and get the body activity upregulated during that time. So we have an increase in cortisol in the morning hours, and we have a decrease in cortisol as we move towards the nighttime hours. The regulation is by short loop and long loop feedback. So we have corticotropin releasing hormone coming from the hypothalamus, stimulating adrenocorticotropin hormone released from the anterior pituitary. And then we have action on the fasciculata of the adrenal cortex, which is going to act to secrete cortisol. So cortisol is going to feedback, long loop feedback onto the hypothalamus. We're going to have short loop feedback from the pituitary onto the hypothalamus, and we're going to regulate that activity. The second messenger is going to be cyclic AMP here, right? So we have adrenocorticotropin release. It's going to attach to the extracellular receptors on the adrenal cortex, and cyclic AMP is going to be our second messenger. Cortisol activity, this is our master stress hormone. So it is going to basically protect the ability of our body to have energy that needs to be used. So it's going to protect plasma glucose levels. It makes sure that plasma glucose levels are elevated so that we can consistently have a supply of energy for our tissue to use while we are in a stress state. It's going to mobilize amino acids. It's going to stimulate hepatic gluconeogenesis, again, trying to get more glucose out there. Stimulates the glycogenesis as well in the liver to continue to produce storage of glucose. Facilitates lipolysis. This is because of subsequent GH release. So if we remember our regulation, increase in cortisol also causes an increase in growth hormone release. And this is going to act on fat to break down adipose tissue. It has an anti-insulin effect on muscle and adipose tissue. So it's going to oppose the uptake of nutrients. Again, this is trying to conserve glucose levels in the bloodstream so that we can have them to use. Next, mineralocorticoid of aldosterone. This is coming from the zona glomerulosa in the adrenal cortex. This is going to be a electrolyte regulator. So this is going to control potassium, sodium, things like that, right? Control mechanisms are going to be from the kidney, right? We have fluid and electrolyte balance there. It's going to be secreted because of the adrenocorticotropin hormone action on the kidney itself. So the adrenocorticotropin hormone released from the pituitary is going to then act on the kidney, which releases renin, which is going to lead to angiotensin conversion to angiotensin 2. And then that is going to stimulate the aldosterone release from this fasciculata there. The effects of aldosterone, it's going to stimulate sodium reabsorption. It's going to reabsorb that from the kidneys. Also, we have less secretion from the sweat glands and less secretion in the gastric juice. So we are trying to conserve sodium. It's going to stimulate the excretion of potassium. So this is the opposite of that. We are absorbing sodium, trying to hold on to sodium. We are excreting potassium. So we increase excretion in the kidney, salivary glands, and the sweat glands. The third mechanism is going to be hydrogen, which is proton excretion. So we're stimulating excretion of protons to try and lessen the amount of circulating acid pretty much around the blood, as protons are contributing to acidic pHs. All right, synthesis of epinephrine. Again, this is an amine hormone synthesized from tyrosine. Epinephrine is going to be stimulated to be made because of tyrosine differentiation. So sympathetic stimulation is going to lead to the conversion of tyrosine into dihydroxyphenylalanine. This is through tyrosine hydroxylase enzyme. Next, we take that dihydroxyphenylalanine and convert it to dopamine through decarboxylase amino acid enzyme. Dopamine is then going to be converted to norepinephrine by dopamine beta hydroxylase. Norepinephrine is going to be either sent out to do its actions, or it is going to be converted to epinephrine. And that conversion is correlated to cortisol. So cortisol is going to stimulate phenylalanine in methyltransferase. Cortisol stimulates phenylalanine in methyltransferase enzyme activity, and this is going to convert norepinephrine into epinephrine, and that is because of cortisol concentrations. Locations: tyrosine hydroxylase in the cytoplasm, amino acid decarboxylase in the cytoplasm, dopamine beta hydroxylase in the granules, phenylalanine in methyltransferase is in the cytoplasm as well. And this is the rate limiting step, right? So the rate limiting step of norepinephrine into epinephrine is going to be at this enzymatic conversion, which is going to be based on cortisol stimulation. All right, so epinephrine release. Epinephrine is your basic fight or flight hormone. It's going to act relatively quickly in times of increased alertness and stress. So the regulation is going to be by sympathetic discharge, right? Sympathetic nerve stimulation onto the adrenal medulla is going to immediately cause epinephrine upregulation. and this is stimulated by stress and hypoglycemia. Metabolic effects of epinephrine, it's going to increase the plasma glucose and free fatty acids, right? And this is partly in conjunction with cortisol's effect because we're trying to get more glucose and fatty acids into the bloodstream that our body can use as energy during stressful situations. So we're going to increase glycogenolysis, we're going to increase gluconeogenesis, we're going to stimulate lipase in the adipose tissue, which is going to be lipolysis effect. We're inhibiting the uptake of glucose to try and buffer that blood glucose level, and it's inhibiting insulin and stimulating glucagon. So we're inhibiting insulin, so we have less drive for the glucose to be taken up by the cells, and we're stimulating glucagon, which is going to increase glycogenolysis and gluconeogenesis in the liver. All right, understanding the thyroid hormone, right? So thyroid gland is going to secrete T4 and T3. T4 is thyroxine, T3 is triiodothyronine. T4 is the inactive form or less active form. T3 is the more active form, right? 80% of the thyroid hormone made is going to be T4. T3 is going to be roughly 20%. It is going to be converted in the liver. Once it's converted from T4 to T3, then it becomes activated, right? So our structure here, we see the base structure of iodine. So iodine is extremely important here. Iodine in our diet is a very important intermediate that we need for thyroid hormone production. We have 4, which is known as tetraiodothyronine or thyroxine, tetra 4 iodines. We convert that and lose one of those iodines. And when we do, we become triiodothyronine, tri for 3. So we have 3 iodines left over, right? So we go from 4 iodine molecules to 3, from thyroxine to triiodothyronine. We're going to have feedback loops here. We have the short loop, ultra short loop, and long feedbacks. We have TRH, thyrotropin releasing hormone from the hypothalamus. We have TSH, thyroid stimulating hormone, secreted from the anterior pituitary. And then we have thyroid gland release of T4 and T3. The process of changing from thyroxine to triiodothyronine is known as deiodination. All right, so synthesizing thyroid hormone. Okay, so first, what we have to do, we have to take thyroid peroxidase, and what we're doing is taking that and converting Tg plus I minus. All right, so in the cytoplasm of the cell, we have amino acids that are going to be secreted from the endoplasmic reticulum. We have a thyroglobulin, which is then going to be put into the Golgi apparatus. We have the vesicles of thyroglobulin that are secreted, and they're going to merge with the cell membrane of the cytoplasm and be released to the extracellular space. All right. That thyroid globulin is going to be attached then to T3 and T4. Okay. Then we have conversion down here, right? We have conversion from Tg into this area here. Okay. So we have colloid droplets that are going to be secreting through protease enzymes. And we have degradation of the protein here, the amino acid tyrosine. Sorry, I almost lost tyrosine. Tyrosine being converted through protease enzyme degradation into T3 and T4. All right, so thyroid hormone here, we have mostly bound to plasma proteins. We have 99% bound to plasma proteins there. There are 3 kinds that we see mainly attached to thyroid hormone here. TBG, which is thyroxine binding globulin. We also have TBPA, which is pre-albumin. And then we have albumin, which is the largest. T4 and T3 are our main ones. All right, so T3 is activated at the tissue level, as I stated before. We have 80% circulating as T4. It is only changed and deiodinated into T3 during tissue activation. Some physiological changes that we see to protein binding. Number 1, during the case of pregnancy. During pregnancy, we have an increase in plasma proteins. that means that we are going to end up with an increased bound concentration of thyroid hormone. So we have more thyroid hormone overall in pregnancy due to increase in binding. During liver disease is going to mean that plasma protein production is downregulated. Liver dysfunction is going to cause less liver activity. Less liver activity means less production of plasma proteins. Less plasma proteins means that there's going to be less thyroid hormone bound in the bloodstream. And that also leads to less total overall thyroid. Thyroid hormone is the master metabolic regulator. So its two effects are calorigenic and fuel metabolism. Calorigenic effect is producing body heat. So it produces 40% of the body heat that we make. It also increases metabolism for all cells. So it's going to increase the turnover of our nutrients, carbs, fats, and proteins. It has a sympathomimetic effect, meaning that it mimics the sympathetic nervous system, stimulating beta receptor cells. It acts as a positive ionotrope and chronotrope in the cardiovascular system. That means that it's going to increase the frequency and strength of heart contractions and heartbeats. And in the nervous system, it's essential for normal neural growth and function. Diseases of the thyroid axis. If we have normal functionality, it's known as a euthyroid. Okay, so a euthyroid is normal thyroid hormone release. In the case of a goiter, which is a growth on the thyroid gland, this can be formed because of excess TSH stimulation. So excess TSH sent from the anterior pituitary to the thyroid can cause goiter formation, right? And this can occur with either hyper or hypothyroid conditions. For hypothyroidism, this is a low plasma T4 or T3. This can come from three different things. It can be a TRH or TSH deficiency. That is going to be leading to no goiter formation because the thyroid gland is not being overstimulated. Then we could have goitrous hypothyroid, which is going to come from dietary deficiency. So if we have a dietary lack of iodine, this is going to be where the thyroid itself doesn't have the ability to make thyroid hormone. So we have increased TRH and TSH because they are trying to stimulate thyroid gland to make more thyroid hormone, but thyroid hormone cannot be made because we don't have external intake of iodine that's efficient. Finally, we have a cretin. So hypothyroidism and cretinism is going to be a disease where we have cold intolerance, lethargy, and mental retardation. Next is hyperthyroidism, which is excess thyroid hormone production. Thyroid stimulation can occur from second or third degree hyperthyroidism, or when what we categorize as Graves' disease, right? So Graves' disease, this is an autoimmune disease. This is where we have TSI, which is known as thyroid stimulating immunoglobulin, autoimmune response, okay? This is going to stimulate the thyroid gland, and it's going to act like TSH would. So TSI is going to stimulate the same receptors that TSH would, causing an overproduction of thyroid and leading to Graves' disease symptoms. All right, calcium and phosphate metabolism. These are both tightly regulated. Calcium is very tightly regulated. It has a concentration of roughly 10 milligrams per deciliter of blood, right? Parathyroid hormone is going to be on the back of the thyroid. It's going to exist in 4 units, right? Primary actions here are going to be to secrete parathyroid hormone from the parathyroid gland, and we see that is going to cause extrusion of calcium and phosphates from the bone. So it's going to cause breakdown of bone to get calcium and phosphate into the blood. Calcitonin is going to be the other one here. It's going to be produced by the thyroid gland from the parafollicular cells. It's a protein hormone that is primarily going to inhibit bone resorption. So it's going to stimulate bone deposition, so increased storage of calcium and phosphate. Finally, we see the regulation by vitamin D. This is 1,25-dihydroxycholecalciferol. This is going to be the steroid hormone. We primarily get this from the diet and also from the skin. The action here is to increase intestinal absorption of calcium. Secondly, we have phosphate regulation. Phosphate regulation is going to be influenced by parathyroid hormone, or it's going to be indirectly influenced by calcium concentrations. So phosphate is going to be important in buffering systems. It's going to be an important portion of ATP, which is adenosine triphosphate, our cellular energy metabolism, and membrane phospholipids. Parathyroid hormone secreted by the parathyroid gland. It's going to have two actions in two places, on the bone and in the kidney. On the bone, it's stimulating osteoclast activity, right? So it's stimulating the osteocytes and osteoclasts to break up bone tissue and extrude that calcium into the blood. It's also going to inhibit bone collagen synthesis by osteoblasts. In the kidney, it's going to increase the resorption of calcium from the distal tubules of the glomerular apparatus. It's inhibiting reabsorption of phosphates, and it's stimulating the synthesis of 1,25 vitamin D3, or dihydroxycholecalciferol. Calcitonin is going to work in the opposite direction. This is going to inhibit osteoclast activity, and it's going to increase the osteoblast activity so that we can store more calcium. It also controls connective tissue secretion. So hypercalcemia will stimulate calcitonin secretion. Also, if we have an increase in postprandial release by action of gastrin, okay, which means an increase in calcium release by gastrin. So if we increase calcium, we're going to increase calcitonin. If we decrease calcium, we're going to decrease calcitonin. Sources of vitamin D3, we get this from fish oils, liver, we get it from milk. We also produce it in the skin as 7-dehydrocholesterol, and that's usually the main source for most people, stimulation of UV rays from the sun. This is going to come in as a precursor for vitamin D. So we have to take it through 3 enzymatic reactions in order to get to active D3. We have 25-hydroxylase, which exists in the liver. We have 1-alpha-hydroxylase, which exists in the kidney, and we have 24-hydroxylase, which also exists in the kidney. So if we're going to take it to the active form, right, we have to go through 1-alpha-hydroxylase. If we take it to the inactive form, we go through 24-hydroxylase. So the precursor that's made in the skin is going to be 7-dehydroxycholesterol. Also, we have dietary intake of vitamin D. It's going to go through the liver, and as soon as it enters the liver, it undergoes enzymatic conversion by 25-hydroxylase. Then it becomes 25-dihydroxycholecalciferol. If we have conversion by 24-hydroxylase in the kidney, then we go to 24-25-dihydroxy vitamin D3, which is going to be the inactive form. If we have stimulation of the active form, it's going to go through 1-alpha-hydroxylase activity, which then becomes 1,25-dihydroxycholecalciferol, which is the active form. Now, this is going to be regulated by PTH, or parathyroid hormone. Parathyroid hormone action in the kidney is going to lead to either the inactive form or the active form. An increase in parathyroid hormone is going to stimulate conversion by the 1-alpha-hydroxylase enzyme. A decrease in parathyroid hormone is going to stimulate the 24-hydroxylase enzyme. All right, actions of D3. It's going to stimulate calcium binding protein in the intestinal cells, so we increase the absorption of calcium in the intestine. It's going to work in the bone. It's inducing mineralization and calcification. It has an osteolytic effect with PTH. Vitamin D3 synthesis is going to be controlled by PTH. Increases in PTH stimulate that 1-alpha-hydroxylase activity. Also, we have negative feedback. So if there is a large concentration of 125 vitamin D3, it's going to inhibit the 1-alpha-hydroxylase activity as a negative feedback loop. Control of 24-25 dihydroxy vitamin D3 synthesis is going to come from parathyroid hormone again. An increased parathyroid hormone inhibits the 24-hydroxylase enzyme. And also, if we have an increase in 125, it's going to stimulate 24-hydroxylase activity to convert the rest of it to the inactive form. All right, pathologies of calcium balance. Hyperparathyroidism, this is also known as hypercalcemia. This is where we have too much parathyroid hormone being made, so there we have bone resorption to an excess degree. We can also get calcium stones in the kidney. It can lead to muscle weakness, excessive loss of calcium, cardiac rigor, which means ventricular muscle contractions are enhanced and frequency is too much. So we lead to the inability to relax, which is also known as rigor. Hypoparathyroidism or hypocalcemia. This can lead to tetany or hyperflexia due to muscle excitability and spasm. Right? It can also lead to spontaneous depolarizations and decrease the nerve threshold for muscle excitability. Finally, vitamin D deficiency. In kids, this can lead to rickets, which is the malformation of bone growth, right? In adults, it leads to either osteoporosis or osteomalacia, which is the degradation of bone that can lead to porous bone, which can be easily fractured or broken. All right, that was the endocrine system and all of the endocrine hormones. Thank you all for listening. Remember to subscribe. Also, go to the Patreon, subscribe to Twisted Science if you'd like more videos. Thank you all for listening, and I'll see you at the next time.